now I'd like to hand over to Neil to start the discussion tonight. So over to you, Neil.
Good evening. So my name is Neil Houston. I'm a GP. I was a GP in rural practice in Scotland, and I have had an interest in patient safety for quite a few years, and ended up being involved with the development of approaches to improve safety in primary care, which spread to over 1,000 GP practices. And I'm in Auckland for a year. Well, my year's almost up. Trying to use those approaches in Scotland and spread them to more practices and community pharmacies in New Zealand. So the title of my talk is First Do No Harm. And it's about practicing more safely, and I think practicing more safely is good for patients, but it's also very good for us. I know as a GP, the things I used to worry about when I came back from holiday were, you know, a misdiagnosis or a result that I'd not acted on appropriately, or a failure to make a referral. So those are some worrying things used to worry me, and they would often had a sort of safety element to it. So if we can practice more safely, then it's good for us and it's good for our patients. So the aims of the session are to learn and think a bit about where does harm occur in our practice, to look in more detail about where does the harm occur, and about prescribing and results handling, and then think about how can we make those areas safer. And I want to share with you some practical ideas to improve safety that have been developed by GP practices in Auckland that have been part of a safety and practice program for the last 3 years. So I think we're all familiar with Hippocrates, who said one of our key functions is never to do harm to anybody. And there's lots of different elements of quality, but I think it's widely believed and that the first thing is to practice safely. I mean, efficiency is important, and being effective and having equity of healthcare is important, but actually being safe is of paramount importance, and it's often a real professional driver for us all. So just looking at the statistics, this is some information from America, which just shows that over 70,000 patients are killed each year in America through medical error. So that's more than road traffic accidents, breast cancer, and HIV. So they describe it as a jumbo jet full of people dying every day from medical error, and we're not really aware of it because these deaths and errors are scattered all over the country, and they're not necessarily very highlighted or brought together, but it's large numbers. Most of the work on patient safety has been in secondary care, and that's where I suppose they do more things that are harmful to patients. They can remove the wrong kidney, they can remove the wrong leg, they can put chest drains into people with central lines that can cause infection, and they certainly deliver toxic drugs, chemotherapy, and so on, which creates a lot of harm. And they reckon that I think 10% of patients in hospital suffer some form of harm from the care they receive. So I'd just like you to take a minute yourselves, just in your own home or your office, just have a think about what is your experience of where things go wrong in primary care. And if you've got an example of something specific or an area that you'd like to flag up as being harmful or risky, then could you just post that to us, and we'll capture people's experience. So I'm just going to give you a minute just to think about that.
There's a few things.
I'm getting a few responses, which is good. So we'll draw those together and come back to those in a few minutes and just share the common experience of some of our traumas. When I was a hospital doctor, I made a mistake and gave somebody an overdose of a drug, and I felt really terrible about that for long periods of time. And then I realized it actually wasn't all my fault. It was a lot to do with the situation that I was in. And I often tell this story at meetings, and what happens at coffee time is they get all these people coming up to me and saying, oh, you thought that was bad? Well, I've got a much worse example. Okay, so thanks for that. We'll come back to that. So Can you flick that back to me? I think it's.
Yes, there we are.
Okay, so how safe are we? Well, actually, we're pretty safe in our consultations. 98 to 99% of our consultations are safe. But the people that are less safe are the frail elderly, the people with multiple morbidity, multiple medications, going in and out of hospital clinics, maybe seeing lots of different people in our practice. And although these are safe, it's the volume, the number of people that we see that makes the incidence of harm high. And the Health Foundation did a review of harm in primary care and concluded the absolute number of those harmed may be just as large or greater than secondary care. So I just want you to, on our poll, how do I put this on, just say which one of the following caused the most harm to patients in primary care, and just take a few seconds to think about this, and then we'll see what you think.
So a little poll should pop up on the screen. Excellent. So great, we can see some good responses coming in there with a bit of a spread.
Okay,
really
so what have we got there, Vicky?
It looks like in the lead we've got prescribing errors, 42% of people in favour of that. The next most common looks like failure to manage test results at 26%. Closely behind that, medication adverse effects, and then I guess less than 10% in delayed diagnosis and failure to refer. So
okay, thanks very much. Okay,
close that poll off.
Thank you for that. Thanks for your response. So, are you able to flick that over to me again?
Sorry, yeah, there we go.
Okay. So, what does the evidence say? Well, the evidence would say that actually medication adverse effect is the most significant harm to patients. So, we may be prescribing them appropriately, but patients are experiencing harm. But there's also unsafe prescribing, or that can make it more likely that patients are harmed. Delayed diagnosis is a big issue, and the research, and it's probably our Achilles heel. I think but the evidence would be that we're probably good at picking up things like cancer, but we're not good at picking up patients who are deteriorating. So patients that have got sepsis, patients that have got renal failure, patients that have heart failure, and that's where the biggest harm occurs. But there's lots of system issues, as you've highlighted: prescribing errors, administration errors with records, patients being misidentified, the wrong patients being referred, or results in the olden days probably more being filed on the wrong patient records. Lots of issues, as you highlighted, around about results handling. It's a huge workload area. We're going to come and talk about that later on today in a lot more detail. And absolutely, communication is key. Communication within our teams, communication at the interface, communication with patients is a real source of harm. So if we look at medication, the evidence would suggest that 6.5% of all admissions to hospital are related to adverse drug reactions. That accounts for 4% of bed capacity, and that 2/3 of these are preventable. So we've got another poll coming up. Which of the following groups of drugs do you think cause the most harm?
The responses coming in. Thank you, everyone. Got non-steroidals out there in the lead from the get-go.
Okay.
By the looks of it.
Okay. Do you want to just give us the percentages?
So summary so far, we've got over 50%, 54, 55% non-steroidals, about 22% anticoagulants or antiplatelets, 13% for antihypertensives, 10% for opioids, and 1% for the oral steroids so far.
Okay, that's great. Yeah. Thank you very much for that. 70%, 71% voted, so thanks very much for that. Okay, we are back on here.
How accurate are we? Let's find out.
So what does the evidence say? Well, we are pretty accurate. You are accurate. Deaths most often associated with non-steroidals and antiplatelets. Half of these preventable drug-related admissions involve 4 groups of drugs: antiplatelets, non-steroidals, anticoagulants. I missed out diuretics because we didn't have enough options.
We couldn't fit it on our poll.
But actually, that was the thing that surprised me. prescribing of diuretics is harmful, particularly with patients that have got impaired renal function. And another 29% of these admissions are due to 4 other groups of drugs. So it's oral steroids, anti-diabetic drugs, antihypertensive drugs, and cardiovascular drugs. So even if we focused on these 8 groups of drugs, we can have a significant impact on admissions and harm to patients. What about New Zealand harm? Well, there was a study carried on by the Health Quality and Safety Commission that showed that 8% of primary care patients who responded to a survey in New Zealand report being given the wrong drug or dose in the last 12 months, and almost half of these had to seek help for their error. So again, experience of patients and users is that that drugs are associated with problems. And they did a survey of medication-related harm in New Zealand hospitals that was published in August, and over a quarter of inpatients experienced harm. Over a quarter of these originated in community and precipitated an admission. And interestingly, opioids and anticoagulants caused 40% of the harm. And the harms were significant: hypertension, bleeding, delirium, confusion, and constipation. So opioids, I think, in New Zealand is appearing as a bigger form of source of harm. They've done some work in Waitemata DHB of admissions to hospital, and again showed, significant numbers of patients with coding of harm from drugs, and again it was non-steroidals, opioids, anticoagulants, and antihypertensives. So consistency really there. So any comments? So what are people feeding back then, Vicky, about their experience of harm?
So certainly the anticoagulants are featuring. So some of the harmful experiences we've heard about: warfarin being taken twice a day after a patient called by the receptionist. So I'm not sure whether that sort of speaks to who's sort of giving advice. Phone-in prescriptions or just repeat prescriptions for different people in the practice seem to be a common source of concern. A few, interestingly, about the presence of students in practices and the consequent, I guess, resource required to manage that and manage things safely so that patients are being seen appropriately. There's an incident, someone reporting today of I think it says a missed fracture.
Okay.
As a result of a bit of confusion with a number of students. And generally communication, particularly primary to secondary.
Yeah. Okay.
Yeah.
Absolutely.
Yeah.
Okay. So again, a few interesting issues around about students, but on the whole, your experience of where things go wrong is backed up by the evidence, and I think that's really interesting that we actually know intuitively where our risks are and where should we be focusing. So the first case is a 78-year-old woman who presented in August 2013 with a painful knee and was given a diagnosis of osteoarthritis. So she was prescribed non-steroidals without gastroprotection. She had some blood tests done at the same time which showed a raised creatinine and a reduced EGFR, and the comment was that she had moderate decrease in her renal function. So those test results were never followed up or repeated, and the patient returned a month later and was given an increased dose of ibuprofen to 800 milligrams twice daily. And then the following 3 years, the patient continued to be given ibuprofen with no review of that documented in the notes. The patient attended, but there was no reference to her arthritis or her pain control, and she certainly had no repeat blood tests. So then 3 years after her initial diagnosis, she presented with fatigue and feeling unwell, and she had some investigations done which showed that she had severe renal impairment caused by chronic interstitial nephritis. So this was a case that actually was looked at by the Health Disability Commission, and they came up with a number of findings. One was the patient's renal functions weren't monitored after 2013 when it was abnormal. The doctor continued to prescribe ibuprofen when, in that particular patient, that's a more risky prescription. The doctors didn't appear to follow basic principles of pain management or stepping up and down treatment, thinking of alternative treatments. And they also criticised the fact that foam was 800 milligrams twice daily, which was the patient couldn't titrate to step up and down easily. they had repeat prescriptions without a face-to-face consultation. That mirrors some of the talks before, and that they didn't do appropriate monitoring. So I suppose the question we all might ask ourselves is, could this happen in our practices? And I certainly think that patients are prescribed I'd like to think that we react to abnormal test results, but I couldn't be 100% sure. And absolutely, there are patients who seem to slip through the net that go on non-steroidal prescribing, who are elderly, perhaps with some renal impairment, that we should be picking up and looking at in a bit more detail. I wonder how many of you think that could happen in your practice?
Certainly a couple of comments that suggest people might agree, particularly identifying the I guess the gap between the knowledge about OTC prescribing or use in cases like this.
And that's a whole different risk area, is the whole thing about OTC. So when I was looking at this case, I was thinking, what did I think were the possible reasons for these failures? And if you've got any suggestions, then just please add them in. I had a bit of a think myself, but I just want to, before that, just talk about where things go wrong. I don't know how many of you have heard of the Swiss cheese model of where things go wrong. So quite often in healthcare, then small things go wrong, a bit like holes in the Swiss cheese, but they don't go anywhere. But actually, when all the holes line up, a whole series of often relatively insignificant events, we get a major hole appearing and a major harm. And my experience is when you look at complaints or you look at a significant event, that's often the feature, is a number of things going on. It could be someone on holiday, you've got a locum, somebody ill, very busy, maybe the day after a public holiday, there's confusion and not normal situation that then predisposes things to go wrong, and then something happens, a mistake is made, and it's just mistake compounded on mistake, and then you get something significant. So just thinking a bit about what makes us more prone to making mistakes, and there's a whole science around about this called human factors, and they've looked at where things go wrong and why, and stress can certainly make us more prone to making mistakes. Fatigue, time pressure, the poor design of our systems, of our IT, particularly interface between some of our IT systems, but also between primary and secondary care and some of our other colleagues, that actually if information is presented to us in a way that's undifferentiated, or we have, for example, multiple alerts about trying to prescribe, we ignore them. 90% of our alerts to do with harmful co-prescribing of drugs, we ignore. That if our care is fragmented, if our teams are fragmented, if we have unfamiliar people joining our teams, then we're more likely to make mistakes. And when I look at this list, it reminds me quite a lot of clinical practice in primary care.
Yeah. Certainly, borne out by the comments too, people saying that, the time pressure, stress, seeing multiple providers, so all things that you've identified.
And that's the reality. I mean, interestingly, in the airline, they have something called a sterile cockpit. So when planes coming into land or taking off, they don't allow any interruptions of the cabin crew. But in our clinical work, there are times where we need to have a sterile cockpit, I think, but we very rarely get that. We may have it when we're seeing patients, but we're doing test results or prescribing or doing repeat prescriptions that are often done in a haphazard way where we don't have protected time. So I think that's something to think about in our own practices, and thinking and realizing where things go wrong. So when I was looking at this case from the HDC, I was thinking that perhaps what were the possible factors? It could be basic lack of knowledge. It could be a lack of continuity of care, locums coming in, the patient seeing a different doctor each time. It could be workload. The patient is elderly, comes in with multiple problems. You have relatively short consultations here, so it's difficult to catch all these things. You have the patient's agenda, then you've got your own agenda. That perhaps repeat prescribing was such that it allowed these non-steroidals to go through without any kind of clinical oversight. That the systems for result handling may not be as reliable as they should be, and that we get this alert fatigue that I talked about, and clearly the patient factors. The patient may not have wanted a gastroprotection, they may not have wanted to have any other different medications. So from his analgesia. I mean, if that's the only thing that makes a difference to me, doctor, is ibuprofen, that's the only one I'll have. And so, you know, I think there's lots of possible reasons, but interestingly, HDC came down very heavily on the doctor, or one of the doctors, and it may be that, you know, I think there's always that blame culture. We should be thinking about what are the broader reasons for things going wrong, and because you have, you know, I think appropriate blame is okay, but we shouldn't ignore other factors that might, if we analysed them, identified them, then they're more likely to bring about change to prevent this recurring, rather than the doctor just has to try a bit harder, which is often the response. Okay. This case also brings up the whole thing about test results, and the World Health Organization identified that rates of test follow-up remain suboptimal. You get lapses in patient care, delays to treatment, and litigation. And there's quite a lot of evidence that practices don't track test results correctly. I think it's perhaps better here in New Zealand than it is in the UK, because you have got good electronic systems, but practices often don't have protocols on how to inform patients of the results. What is the practice's responsibility? What is the patient's responsibility? Lots of communication issues. So when the doctor sees a test result, do they clearly communicate? Do we clearly communicate what we want to happen? What are the implications of that test result and what's to happen next? And the Medical Protection Society looked at over 400 practices in the UK and found that more than 84% of them had risks associated with test results. And if you look at, again, at the Health and Disability Commission cases, a lot of them are linked to lack of follow-up of test results. I think the other thing about tests is that it's absolutely huge workload. They reckon that we're doing 15% increase in tests, in blood tests year on year. So that's a massive amount, and it's a huge stress on us. I read another survey that said that the doctors often can spend more than 75 minutes a day managing test results, and it's often after hours when the surgery is closed, because that's when we get time to do it. So, you know, if we can make this safer and more efficient, then there's benefits for everybody. So what can we do about it? So as I said, in Scotland, we had a national patient safety program where we tested and developed some approaches to improve safety. And in 2014, I came over to New Zealand to talk about the Scottish experience, and the DHBs and the PHOs in Auckland said this is something that's really interesting, and we're going to copy this in Scotland and test approaches. So they set up a program called Safety in Practice, and it's been on the go for 4 years now, and it's a quality improvement initiative with a focus on safety. So I supported, but there's some really able local clinical leadership. Vika Sethi is the local clinical lead for counties Manukau, and Lisa Eskeltison is the clinical lead for Waitemata and Auckland DHB, and they've got a lot of experience now in supporting practices. So it's a collaborative practices, DHBs, PHOs, and it's grown from 23 practices to now over 75 GP practices, 6 urgent care clinics, and we've also started working with 20 community pharmacies in the last 6 months. So, and the experience is really very positive. So these are the aims of the program: reducing harm, improving our systems, getting our high-risk processes carried out reliably, promoting a culture of safety. And I think part of that process, practices are taught quality improvement skills, which they then can use for any other problems that they're trying to face. So I think in primary care, a lot of the harm in secondary care is from things that we do to patients. We don't do as much to patients. We prescribe for patients, and that's harmful. But I think a lot of the harm is for the things that we don't do for patients: not following up test results, not reliably diagnosing, not giving people reliable care for heart failure to make sure they're all on the right treatment. So it's a slightly different emphasis. So these are the areas that we've identified as being important: warfarin, medication reconciliation, results handling, non-steroidals, and methotrexate. Methotrexate's low volume but very high risk, and it's a kind of marker drug that you need to monitor well, but there's lots of other drugs that we should be monitoring reliably. So methotrexate, if you can get that right, you're more likely to get your other monitoring done well. So this diagram on the top left is an improvement collaborative. So practices come along to learning sets. They learn about how to improve care in an area. They go away and do tests of change in their practice, and they come back to learning sets. And they're given a whole toolkit box of tools, box of tricks to try out. And the whole idea, not sure where that thing's come up as a spotlight, is to shine, give you an insight into your own practice and your own team to make about change. And the whole thing is to engage with teams, engage with doctors, nurses, practice managers, and involve everyone around a common purpose that people see as a problem for themselves and for patients. So this was a guy, Deming, who says, "In God we trust, all others bring data." And I've heard another quote about data is, data will first piss you off and then it will set you free, because you actually need to collect data to see how good our systems are. But if you then can see that your system's reliable, you can relax a little bit. So Emirates Team New Zealand, I'm sure, won the America's Cup because they made lots of changes and tweaks to what they did with the boat, but they were constantly measuring what they did, and it was only through that measurement could they work out whether they were getting better or not. And we really need to do that in healthcare as well. So the approach of safety in practice is to do something called a bundle approach, which is a bit like audit on steroids. So you look at 3 to 5 elements of your care in a particular area. The measures are across the patient's journey, so different members of staff doing things reliably. And because it's across the patient's journey, involving lots of staff, you have a united approach to it, creates teamwork, and you have some easy measures and some hard measures. Clinical audit, you would measure 3 or 4 indicators, and you do a big sample at one time, and then hopefully go back maybe a year later and find out if you'd made a difference. Whereas what you do in this bundle approach is that you measure 10 patients a month, and then you can see whether there's improvement. So if we go back to test results, this is a system for managing test results, and the safety and practice focus on test results focuses on the bottom section. So it's what happens to the test results to the practice. Are they reviewed? Are comments put on the test results? Are they actioned? And is the patient informed? And do what happens next? Does it happen? So we're measuring that second half of the process. So what we measure is, has a decision been recorded by a clinician on each test result within 7 days of being received? Have the decisions for each test result been actioned by the practice, including getting the patient back? And has the patient been informed as instructed? And then you measure whether, from these 10 sets of records per month, whether the patient, each test result has these 3 elements of care, but also whether all elements of care are included. So if you have a look at this graph, you can see there's an overall compliance in the bottom right-hand corner. So you can see very clearly that this way allows you to identify what you need to be focusing on. So for this practice, well, actually this is an accumulation of 20 practices who did results handling last year. It shows that the main thing they need to focus on was actually the clinician having a look at the test results and having a definitive decision on every test result that was communicated. And then you can see over time that included, we've got something coming here. Stop the sharing your webcam.
Oh, yep, that's fine. You can just carry on.
Okay. How do I get onto this?
Let's get rid of that. Yeah, perfect.
Okay, so what were the things that practices did? Well, it prompted a lot of discussion around about communication. So the receptionists and nurses were saying the doctor's comments are not understandable or helpful. So this prompted practices to sit down and say what actual comments are useful for and understandable for everybody, and let's agree a fixed group of comments that we can then link to quick keys, which then go onto the patient records. They go onto the patient portal. Doesn't mean say you can't do free text around about it, but it's a very quick way of putting a comment on a patient's records that actually everybody can understand. And practices are reviewing these comments on a regular basis and say which ones are good, which ones are not so good, how can we improve it? And that's been a huge change to practices and really successful. One practice at Auckland Experience showed that actually it meant that the nurse's workload went down because they didn't have to go back to the doctor and say, what do you mean by this test result? Much more efficient communication, practices using the patient portal and GPs and patients using the patient's portal, nurses being more confident in giving test results to patients, and consistency and patient satisfaction was increased.
That seems to fit with a couple of comments coming in.
Yep.
I'm not sure what role the person who made this comment has, but just commenting that there's often ambiguous messages from the GPs about results, and it can take days to track down the actual meaning.
Yeah.
So, like you say, that would increase the workload and make people pretty unhappy, I imagine, over time. So
we had a medical student in our practice who said, "Oh, you've got great systems, but the receptionists have no idea what no action required means."
All right.
You know, when they dig it out to patients, is it normal, is it abnormal? So that then brought us to this whole thing about having standardized comments, and it's gone from there. And I think it's a really useful process, because then everyone in the practice begins to understand what the process is for roundabout test results. And the other beauty of this was it led that practice to start to think about other improvements they could make in other ways. This is just some feedback from practice being part of it. Huge improvement in ease of communication, significant tangible improvements in efficiency, and I think that's really important. If you can become safe, you can often become more efficient as well. And actually working around test results, which everyone sees as a problem, really increased satisfaction and became a very cohesive team as a consequence. Just about some other changes. It led to the practice keeping much more up-to-date contact details for patients so they could communicate roundabout test results. It led to members of the team, like the GPs, having a better understanding that if they didn't do their job that well, roundabout test results had such a knock-on effect on other people in the practice. It led to agreed timescales, better patient education, so the patients understood what their experience and what was their requirement and their role was roundabout test results. So any kind of comments or questions round about that bit of work?
There's been a couple coming through. One, is it possible, I guess, through this system to track incidents where results aren't followed up and there might be a harm from it? Is there a way to?
Well, I suppose part of it is you're looking to see whether the actions have been carried out. So that's led to practice having systems of making sure that the patient comes back, or the patient's communicated, or the patient makes an appointment or has a follow-up test result. So it's led to, although the area of focus of the test results is quite limited, what's happened is the practices have then expanded that view to cover X-ray results, what happens, you know, a month down the track, and also whether the patient actually goes for their blood test.
Yes.
You know, so it's a really complicated area, but by focusing on one area that everyone can agree is important, you then get a kind of spread of other activities.
Sure.
Yeah.
And will that spill over into even one area that's been identified on the questions is when GPs are asked to follow up results from hospital, and that seems like a common area of concern.
I think that's really difficult. I'm not sure.
Really hard.
I think the program is to focus on what's the practice's responsibility, and I think that's a whole really contentious issue. And I've seen some work in Auckland which seemed to indicate that GP practices were to start following up on every test result that was done in hospital, and I just think that is just so complicated. It needs to be very clear about whose responsibility it is to act on them. So, but again, it's hard enough, it's risky enough when the process is within your practice. If you then start to bring in secondary care, it's really difficult. You know, certainly something that used to make me very annoyed when I was asked to chase a test result.
Yes, indeed. I'm sure you're not alone there. There's just a couple of comments about whether just tracking the results and the actions have resulted in maybe fewer tests, or people perhaps choosing more carefully about which tests they do. I'm not sure.
I'm not sure we've got evidence of that. I think we did when we looked at a focus on warfarin. We actually found that having more reliable systems for managing warfarin meant that patients were in better control, and so there were fewer test results being done. That practices were often repeating blood tests too quickly, or they weren't following guidance in terms of managing warfarin. So I think I can see that as an example, but I think a lot of it's about clarity when the doctor sees the test result, what they expect to happen next, so reduces any misunderstandings. So I don't think there's evidence it means greater efficiency in that sense, but it's certainly greater efficiency of communication with patients and processing these vast number of tests that we're doing.
Right, okay. That makes really good sense. Yeah.
Okay, so the next case is about medication reconciliation. So this was in January 2017. Practice, a doctor noticed that a 72-year-old man was on clopidogrel and warfarin, which is unnecessary and potentially very harmful. And when the doctor reviewed the notes, the patient was on warfarin, had been on warfarin for 5 years, was admitted to hospital the previous August when the warfarin was stopped and the patient was started on clopidogrel. So the patient was discharged, but the patient wasn't seen at discharge, and there was no medication reconciliation really done at that point. The warfarin wasn't taken off the list, the patient wasn't seen, there was no discussion in the notes, as far as we could see, with the patient to clarify changes in the medications, and so the patient continued to take both medicines. And this kind of raises this whole thing about how reliable is our system for doing medication reconciliation at discharge. Something that I was very unsure about in my practice for 20 of my 25 years there. I was never clear whose responsibility it was and how do we record medication reconciliation and who does it. And it was only after we started to look at it with a degree of focus that it became very clear whose responsibility was, and we started to do it reliably. We started to make the changes, we started to communicate with patients, and we started to record that process. So I think there's quite a lot of evidence about medication reconciliation. I'll just talk a bit about that. So more than 40% of medication errors result from inadequate reconciliation in handovers, and that a considerable percentage of those are associated with harm. So there's lots of evidence it's not done well in hospital, that the discharge letters are inaccurate and delayed, and I think everyone would nod about that. But actually, there's quite a lot of evidence that we have unreliable systems in place in primary care, that it's not done reliably. Sometimes it's done by members of the admin team, that it's not recorded that well. And so the Safety and Practice Programme has an aim that all discharge summaries will be reviewed with both medications reconciled and actions completed within 7 working days. So again, it's got a time frame on it, and we get practices to look at 10 sets of records of patients that have been discharged, preferably from a medical ward, and you look and see, has the medication reconciliation occurred within 7 days? Has the list been updated if there are changes? And I think a key thing, is it documented that any significant changes have been discussed with the patient or their representative? So this can be a bit contentious. Significant we describe as being a change, a chronic medication being started, stopped, or dose changed, because actually patients are often told these things in hospitals, but they're unwell, they're about to be discharged, and they forget. So it's really important that we do this in practice. Who have communicated with patients around about this find that the patients really value it, and there has been a lot of misunderstandings discovered as a consequence. So 10 sets of records per month, and again, you get this you get this picture of improvement over time. So this is aggregated figures from all the practices in Auckland that were doing MedRec. So the medication changes may have been done, but they weren't necessarily documented. They weren't done at the right time. That they weren't necessarily updated in their records, and there certainly wasn't a lot of communication with the patient. So you can see how this process can give you a kind of real-time view of how improvements are made. So I quite like this proverb, you can't fatten a cow by weighing it. To me, that means that you won't change anything just by measuring. So what changes could you make around about medication reconciliation? Well, clearly one of the things is to discuss it as a practice and find out what the problems are around about it, work out whose responsibility it is to do it, who should communicate with the patient. And some practices have recorded the medication reconciliation much better, but then they're leaving it to perhaps a nurse to phone the patient afterwards. It doesn't all have to be the doctor. So one of the changes that practices have brought out is have used is this way of recording medication reconciliation, and this is where I'm a little bit vulnerable because I don't work in clinical practice in New Zealand, but this is from MedTech. So they found a way by using a medication status category that you can record a medication dose altered or drug stopped or started, and so you get a very good record of where that list of medication came from, and it's very clear that medication reconciliation has been done. And practices are finding it really useful when they go back a bit later and trying to work out where did that list of medicines come from. They've got it clearly documented in their notes.
That's really useful, and that's coming through in the comments. Is that it's a feeling I'm so aware of this, and I'm sure other people will be too, that MedTech isn't particularly helpful or intuitive for something like this.
Yeah.
And it's difficult to generate a new list of medicines that keeps track. So this is
Yeah, absolutely. And there's just another example. And, we are in discussion with the IT providers about how can we make these things easier for practices. We developed a template in Scotland which captured it all very clearly about medication done, drugs started or stopped, has the patient been communicated, and it gave a very good record. So we are trying on your behalf to bring about some change in the IT system, because I know this is a real frustration for people. So it's about making it easy for people to do the right thing and record the right thing. So that was, and again, this is something that practices are talking about. What initially the team didn't think there was a problem with medication reconciliation, so it's highlighted that some GPs don't do it well. Clearly agreement that MedRec needs to be documented. They're using agreed created shortcut, again, a quick way of doing it. And actually this whole thing about patients really appreciating the call to discuss the medication changes. Any comments or queries from that, Vicky?
Yeah, I guess just people expressing surprise that this existed in medtech, which is nice, and lots of comments about the need to and how we often do rely on our pharmacist colleagues, which is a resource available in secondary care, of course, and I'm sure in a lot of hospitals, pharmacists are shouldering the burden of the medicines reconciliation work, and there's no sort of equivalent of that in primary care in terms of a clinical pharmacy service. So lots of people suggesting how nice it would be if that was available in primary care. But depending, I guess it's quite practice specific, and depending on the relationship between the practice and the pharmacies.
Yeah, I mean, we're working with these 20 pharmacies in Auckland, and one of the areas they're looking at is medication reconciliation. What's the role of pharmacy around about medication reconciliation? Really encouraging them to take that role to make sure that if they can access the discharge letter, find out, make sure that the next set of drugs that are prescribed, the next prescription that comes through, does reflect what their patient was discharged on. I mean, I would say that it's always an active process, MedRec. It's not about just copying, is it? And from the hospital, it's about you saying, well, this is the right group of meds to go forward. But if the pharmacist is seeing a discrepancy, then they'll contact the practice. And I think, what was the other thing? If people are looking for the guidance around about these, the ways of changing medtech, then if you look on the Safety in Practice website, you'll be able to find under one of the safety bundles under medication reconciliation clear guidance as to how you can do that. Yeah.
Excellent.
Okay.
Some people writing in saying that in some practices there is a clinical pharmacist working with them, which is great, and of course the community pharmacists being involved too. Questions coming in about funding for all this extra work that we might need to do as a result of all this stuff. I guess putting a comment to
the program gives practices $5,500 to be part of the program to come to the learning set. It doesn't pay you to do the work in your practice, because the evidence is from practice that it's to pay them to come to the learning sets. But actually going away and doing it actually has its own rewards. Actually, it does lead to greater efficiencies and teamwork and culture and better systems, and so the practices are, I mean, they like having them, they value the money to help them attend the learning set, but it also helps, I'm going to talk about later, it also helps practices achieve cornerstone. It gives you the material that the GPs can present for their mocks and so on. So all the interventions have been approved by the college for that. So it is a big thing. Where do you get the time to do it? I mean, my advice would be a lot of this work can be done by managers and nurses to do the work and to lead the work, and the GP work is there to endorse it and to acknowledge there's a problem and to change their behaviours if they need to. But it's about other people in the practice taking a leadership, and it doesn't all come back to the GP. The data collection actually is pretty quick. It can take maybe 30 minutes a month of a member of the admin team, maybe a receptionist, to do it. So the data collection itself is data light.
A couple of people just wondering if we can repeat where we can apply for the learning sets for the safety in practice.
Okay, so this we recruit each year, and so this is for Auckland only at the moment, and we're looking to recruit another 30 teams from August. So we will be advertising that through your PHOs. But if you want interested, go to the Safety in Practice website, and you'll see when it comes up. Usually we start recruiting in about May or June. and we start kicking off with the first learning set in August. There's quite a lot of interest in it nationally, so I've been speaking to Lower Hutt, Nelson and Marlborough. I'm going down to Canterbury this weekend. I've also spoken down in Dunedin, and there's lots of interest in PHOs and DHBs to become involved. You've got options of either saying, well, I'll just download the material and try it myself. But if you think this is something that you would like your own PHO or DHB to get involved in, then I would really support you to do that, because I think they are keen to involve general practice in this work, and so I think if they had a lot of keen practice to try it out in an area, I think you might find that you get quite a positive response. There's several ways of getting involved. You can download the material, you can influence your PHO or your DHB to do some testing work in this. Right.
And do people, the rural people far from main centres, is there good access for this?
Well, we're working with Waiheke and Barrier Island, where we're kind of working out how to do that. And I think, you know, if it's a potential, I think there's a potential that this should be available nationally. And I think if people like the HQSC get involved, then they should be developing some teaching online. There's lots of presentations and things that we've developed, and the tools actually are quite self-explanatory. But I think it's important to understand why safety, you know, to share some of that and get that will. We often miss out on the creating the will. We'd go straight into this is what you need to do. And I think safety is so important that people need to think about where do things go wrong, look at the evidence, and then you get a choice of what topic to focus on. I think that's the beauty of the program. You can choose an area that you think is most appropriate for you, although we recommend that people do results handling or medication reconciliation straight up, because they're system issues. They're fairly uniformly, we could do them better. So I think there's lots of ways of getting involved, but I think in Scotland it spread to 1,000 practices, and even with that, you know, in one health board we had 80% of practices saying this was really good work, and it was some of the best improvement work they've done, because it's practical, it's focused on a particular area. Anything else? Excellent.
Yeah, just some comments about Waitemata trialling the telemed solutions.
Yeah, I think there's lots of things we could do. We could link up to the learning site, so you don't have to be there in person. You know, maybe these things like these WebEx you can do. And there's some really good. There's a video on the Safety and Practice website that just talks about the experience of practice that you can have a look at, that can engage your team. VCAS has done some really good videos to describe some of the tools and some of the approaches. So I think we need to work out more to make it more accessible. But I think one of the beauties is coming together, if you can, with your other practices and hearing the solutions they've developed, because it's not about everyone having the same system, but there's certainly lots we can learn from one another.
Yeah, sure.
Yeah. Okay, thank you. So this is just another case. So this was in the press just last week, I think. Death of a patient on long-term diclofenac, long-term use of diclofenac without gastroprotective prophylaxis. Elderly person, GI hemorrhage from a duodenal ulcer, given diclofenac for osteoarthritis again, no gastroprotective medication. Interestingly, the last line, the GP raised the issue on subsequent occasions, but the patient's attitude was that she had been on diclofenac for many years and experienced no problems with it. And that's one of the challenges is that risk discussion with patients.
Yeah.
But, you know, there is a lot of evidence. So we talked before, you yourselves flagged up that non-steroidals are the most, 55% of you said that non-steroidals are the most dangerous drugs, and you were on the whole right. Commonly cause deaths, commonly cause admission. And actually, there's lots of evidence that when we review prescriptions of non-steroidals, we can actually change that risk in about a third of patients.
That's a lot.
Yeah. So just talk about an approach that we have used in Auckland this year. The intervention is giving people practice searches to identify patients at risk. Practice then decide what to do with that information. They often review the patients, make changes to the prescriptions, and then we can see over time whether the numbers of patients who are exposed to this high-risk prescribing reduces. So these are the areas that we focus on. It's a complicated slide, but if you go down the yellow section, we're looking at patients over 65 on a non-steroidal without gastroprotection, because they're 10 times more likely to have a GI bleed than patients under 65. Patients with CKD and non-steroidal more likely to have an acute kidney injury when they're unwell. This triple whammy, this combination of ACE inhibitor, diuretic and a non-steroidal, they've got an 80% increased risk of being admitted to hospital in the next 30 days with acute kidney injury. I mean, that's 80% relative risk. But you know, it's still significant. And again, clearly patients with peptic ulcer shouldn't be on non-steroidals, and patients with heart failure, if they go on a non-steroidal, again, they're more prone to have acute kidney injury or to exacerbate their heart failure. So there's some guidance about, you know, stopping the non-steroidal, giving alternative analgesics, or giving some gastroprotective medication. So those are the searches that we did, and we worked with Dr. Info and Mohio, and so they have these audits in your practice. So every practice who uses Dr. Info should be able to access these searches, although not with MedTech Evolution. So you look at them and identify the patients who are in these high-risk groups. You click on the list and you get a list of patients, and then it's really up to you to decide what to do with it. So the national patient numbers from Dr. Miho, Dr. Info, 2.8 million, shows that 150,000 patients almost in the previous 3 months had been prescribed a non-steroidal without a GI protection over 65, 26,000 with CKD, 5,000 with heart failure, and 3,700 getting the triple whammy. So significant numbers. We did some work in our practice, and we were feeling quite smug because we'd done it and we thought that we'd addressed all these patients, and we repeated the audit about a year later and found that our figures were back to where they were before. And it's just these things that you just constantly need to be aware, because these patients just seem to get on these drugs, and sometimes they're just a one-off prescription, sometimes it's repeat. So that, again, there's information about how you can find these patients using the Audits and Mohio. This information is on the Safety and Practice website under safety bundles, under non-steroidals. All the indications and instructions are there. So this is just one experience of a practice where a student in one practice looked at 10 patients who appeared in the searches, and there was an 80-year-old who'd had 20 courses since 2009, an 89-year-old who's had 35 courses since 2008, and 2 patients with CKD. So these patients do slip under the radar. So big insights for practice, and that was the experience that people were sometimes shocked by the number of patients who came up, and they started to query the searches, and the searches aren't always right. You might get some false positives, but actually there's lots of patients there that you perhaps didn't realize were at higher risk. So this then prompted lots of discussion with amongst prescribers and patients. Dr. Info allows practices to have some daily notification where they can get told that actually today there's a number of patients who are on the triple whammy or not on gastroprotection are coming to your practice. Some practices were obviously reviewing patients. Quite often nurses were doing it, having those discussions and flagging in the notes that they'd had the discussion, they'd stopped the drug, or in fact they given their gastroprotection, or they'd had the discussion with the patient and the patient was happy to carry on, but at least it was documented. So you know, I think the experience is really positive. So we have these 20 community pharmacies working in Waitemata and Auckland DHBs, and this is what they reported at Learning Centre. Actually, they've noticed they still are prescribing non-steroidals, but a reduction in non-steroidals, not doing the triple whammy, and actually practices are open to when the pharmacists contact them, much more open and responsive to it, because the pharmacies are also looking at Medrec, opioids, non-steroidals and warfarin. So that's kind of shared agenda has driven much more closer working relationship with practice. So really interesting data, and we have got the most recent data which shows a decrease in the number of patients who are being prescribed these high-risk combinations. So that, again, these searches are available for, I think, most practices in New Zealand. The change package is there, and this could be a really easy way to start for some practices. It's a bit doctor focused, it'd be my only thing, that actually if you want to do medrec or results handling, you're more likely to engage the whole team. But if you as a doctor want to start this up in your practice, there's no reason why you shouldn't do it. Any questions about that?
A few questions sort of more about the specifics of the sort of numbers needed to treat to prevent GI bleeds with gastroprotection, which I don't have at my fingertips. we might be able to feedback on that separately. And questions, I guess, obviously patients requesting non-steroidals have pain, and I guess following up on their experience if we're stopping the non-steroidals and whether or not there's any tracking or any of your experience following along to see what happens with pain if there's a sort of aggressive.
This isn't to take away a clinical decision making. It's just saying actually maybe you weren't aware of these patients that were on the triple whammy or weren't on gastroprotection. Then you can decide what to do about it. And some practices are saying, well, we're going to focus on triple whammy because we think that's the highest risk. Some practices are having discussions and saying, well, how long is it safe to give somebody over 65 a non-steroidal without giving them gastroprotection? So it's prompting that discussion. We're not saying you must do it. We're just saying this should prompt some discussion about your own clinical practice. And people have brought some really good things saying, what about COX-2s? We're treating COX-2s the same as the others because there still is an increased risk. But again, so some practices are deciding that they're going to think differently, and we're not saying everyone should do the same. As I said, all these tools are about giving you insights into your own system, and there are some solutions there as well, because there's things like SafeRx resources that you can give to patients about non-steroidals and ibuprofen, and the triple whammy that practices can use to give to patients that can help them make an informed decision.
That's excellent.
So again, there are resources
really
there.
Collaborative approaches. A couple more people commenting about other sources of error, I guess, particularly again with the transfer of care between primary care practitioners and results sort of left hanging in the balance between an old and new practitioner and who's responsible in that setting. I guess that's a tricky one. And in terms of medicines reconciliations, I guess people wanting a bit of guidance about who should be responsible for that. I guess what I'm hearing you say is that that's something that you might
I mean, I think probably people would say that, you know, it's a doctor's decision or a pharmacist's decision, probably a doctor's decision when you get that list of drugs back from the hospital, is which ones to continue. Because the doctor, you may remember that a patient's had that particular combination before, it didn't work. It's perhaps not been recorded as an allergy, or the hospital didn't know that actually, that if you start to titrate up their ACE inhibitor, they're going to run into problems. So you make a decision that you're not going to continue that drug, but then you can hand it on to the receptionist, or the nurse, to have that discussion. You know, so you have to do different ways, but it shouldn't all, it's the same with test results. Every practice have a different system. So some practices will say it's not the receptionist's job to give out results to patients. But if the communication is really good around about test results and what the doctor is saying needs to be done, that could, and some practices do give it to the receptionist to give that information to, but it depends on what you're comfortable with in your own practice. That's the thing.
Sure.
Yep. Yeah. Okay, so I think we're getting there. So motivation, somebody said, how do we get the time to do this? And we're all motivated by different things. I mean, I think all profession, most doctors, almost all doctors, I think, are motivated by preventing harm to patients. There are motivations in terms of these tools being accredited for use with the college, that actually if you're doing Cornerstone, then there are elements, results handling, medication reconciliation, prescribing systems are all things that the safety and practice toolkit can help you address. There's also the money, the $5,500 if you're in Auckland, but there's also other real motivations around about, you know, just having your team working closely together, and there's another tool that practice can use, which is a safety culture survey. That everybody in the practice fills in a safety culture survey, and you get a practice report, specific report on your culture that compares you with other practices in New Zealand that have completed it, and again gives you insights into your own practice. So there's various motivations, and I think safety and practice can help. And the other thing is, we reckon for PHOs, actually, if you're reducing harm from medications, you're reducing admissions. So that helps with system level measures. Reducing polypharmacy, you're going to be cutting back on some of your prescribing if you start to look at a bit more detail. So, you know, it does fit with some of the other drivers. And I think what's happening locally is that with more and more GPs coming together, they're starting to flag up interface issues, which then the DHB can take forward and try and address. Sort of communication around about test results, responsibility around about test results, things around about medication reconciliation at discharge. So this work has prompted a whole system approach to looking at medication reconciliation in Auckland that's about to kick off. So there's all sorts of different benefits from being part of this work, but the core thing is it's good for patients and it's good for your practice. So can reduce workload, can reduce stress, help us sleep better at night, and the idea is we have, you know, confident, healthy, fit patients that are exposed to less harm. People asked, how can we sign up? I said that we will be looking for more clinical teams in Auckland and Waitemata DHB this year, pharmacies and GP practices. But, you know, if you want to do something individually, I would encourage you to do it. But if you want to influence your PHO or DHB to start doing some work in this area, I think you might find that they're receptive to it. Clearly, there's lots of other priorities for you and your PHO and DHB, but you know, I think if you can start looking at safety, then you find that a lot of other issues, quality issues, improve. I would suggest you have a go in whatever form you want to do it. All the tools are freely available. That's the website. Really recommend a short video to show to your partners and to say about what are the benefits of video, and have a look at the website. It's not as easy to navigate as it might be, but you can access all the bundles, and clearly if you want to email me, that's great. If you want to email Lisa, then she's the clinical lead for Waitemata and Auckland, and if you'd like to email Vika Sethi, he's the I think the most experienced clinical lead in this area, and he works in counties Manukau DHB. So that's, I think, my last slide.
That's great. Thank you. There's a couple of questions coming up about where to find the MedTech, Medicines Reconciliation screen.
Yeah.
So what we might do with that is possibly put, I wonder if we can put a little screenshot up as an attachment, or a link to.
Yeah, I've got a document that we developed that talks people through how to do it.
Oh, brilliant!
So I wonder if we could send that to you.
Put that on the Goodfellow website.
Yep.
With the.
Yep.
Yeah, we'll put a link to that so that people can find it when they want to go back to their practice and try it out. Lots of thank yous from various audience members and good examples. And I think people generally very positive about getting out there and implementing this. Just trawling back to see if there's any other questions that we've missed. I do apologise if we've missed your questions. There's a significant number of comments about the role of clinical pharmacists in the UK, and people, obviously they're available to some people, but not everyone.
Yeah, absolutely. I mean, I think that we don't have that locally, not very few, but actually if we're working with community pharmacies, for example, if your DHB was one to start working at this and had pharmacists, then I think, you know, the pharmacists are very keen to take on more responsibility for this work. So it is a bit about how can pharmacists and GP practices work more closely and smartly together. Yeah,
it seems like a.
But you're right. I think for a lot of the medication work, you know, community pharmacists can help round about MedRec, but in a lot of practices, the nurses have been involved in communicating with patients and also round about test results. Or you can then just devolve some of your responsibility to receptionists if you feel that you've got good systems and communication is good. So it's in our practice, for example, we looked at test results and the nurses that were doing the chronic disease management, they took all the test results for the patients they were seeing for chronic disease management. So that completely took it away from my inbox.
Wow. Imagine that would make a big difference.
Yeah, because they're the ones that are seeing the patients in the clinic, and if there were clearly significant problems, then they would flag them up to me. But it's just about can help with efficiency and make it the most appropriate person dealing with it. So you get safety, you get efficiency as well. And actually what's really happened is that then a lot of the members of staff who've been part of safety in practice, the receptionists, the nurses, the managers, have had greater job satisfaction. The practice doing warfarin almost inevitably leads to the nurses managing all patients on warfarin.
Wow. Yeah.
So that's led to them having greater job satisfaction, and the doctor's very happy to hand on something that takes time but they don't need to necessarily do. So I think this work really does and what you get is you get nurses and healthcare assistants standing up at a learning set and talking about their experience and how it's improved their the services, but also their own job satisfaction.
Lots of benefits.
Lots of benefits. Yeah.
Well, that's great. I think we've probably come to the end of our time and the content. So thank you everyone for listening. We are really lucky to have you tonight, Neil. So thanks very much. And for the audience, look, the next webinar that we're planning is on the new cardiovascular primary care guidelines for risk management. So details of that are on the website, and also don't forget the Goodfellow Symposium coming up at the end of March in Auckland. Hope to see all of you there. And look, thanks again, Neil.
Okay, thank you very much. Enjoy it. Thanks for all your input, everybody.
Okay, good night, everyone.